Good evening and a very warm welcome to all of you joining us from home and wherever you are, and to our fabulous expert panel to whom I'll introduce you shortly. I'm Professor Vlado Perkovic. I'm the Dean of the Faculty of Medicine and Health at UNSW Sydney, and I'm delighted to be hosting our first MedConnect event for 2021. The topic today is certainly front of mind for the whole community, specifically health leadership in challenging times and our future after COVID. Today, we'll be exploring the future of health leadership and what we've learned from the COVID-19 pandemic to improve our health and also that of society at large. There's never been a more obviously important role for leadership in health than there is today, both in terms of delivering healthcare, but also in considering the impact of health and decisions about health and the leadership that's involved on issues across the broader community. A discussion clearly that's more important today than ever before. Before we begin, I'd like to acknowledge the Bedegal people who are the traditional custodians of the lands on which UNSW stands, as well as the Ku-ring-gai people whose lands I'm joining you from tonight, and the traditional owners of all the other lands each of you are joining from. I'd like to pay my respects to elders past and present, and also to extend that respect to our Aboriginal and Torres Strait Islander colleagues and friends joining us here today. And now it's my pleasure to introduce you to MedConnect, a digital event series through which we explore key health issues that affect our community in a forum that brings together health leaders as well as expert industry viewpoints for what we hope will be a lively and thought-provoking discussion. I'd encourage each of you to participate. You'll be able to pose questions directly to the panelists via the website Slido, that's sli.do, and the hashtag for this event is health leadership, or one word. Through Slido, you can not only add questions and for the panelists, but you can also upvote other people's questions. That'll help us to prioritise the most important issues for us to make sure we cover them tonight. A reminder also that this webinar will be recorded and it will be made public following the session. So now let me introduce the panelists joining me this evening. Firstly, a warm welcome to Cathryn Cox, the Chief Executive Officer of Sydney Children's Hospital Network. Cathryn was appointed to the role in August 2020, right in the middle of our COVID times. Before this, she worked as an executive with the New South Wales Ministry of Health, with responsibility for a range of health policy, planning, infrastructure and strategic reform programs. Cathryn, thank you very much for joining us tonight. Professor Raina MacIntyre is next. Raina's a NHMRC Principal Research Fellow, Head of the Biosecurity Program at the Kirby Institute, and Professor of Global Biosecurity here at UNSW Sydney. Raina has a 28-year track record in pandemics, in epidemic infections, serious emerging infections, vaccines, and control of respiratory viruses. And as a result, has been a key public voice, commentator, and a researcher around the COVID-19 pandemic. Raina, welcome. And lastly, we've got Professor Sir Edward Byrne as our final panellist this evening. Ed's the Chief Medical Officer of Ramsay Healthcare and Vice-Chancellor's Distinguished Fellow at Australian National University, as well as a Senior Advisor to our Faculty of Medicine Health here at UNSW. He was previously President and Principal at King's College London and Chairman of King's Health Partners board from 2014 until early 2021, having previously served as Vice-Chancellor as well as Dean of Medicine at Monash University, a background of a long career as an eminent neurologist. Ed, welcome. Dr. Kerry Chant was planning to join our panel this evening, but unfortunately, albeit understandably, she's not able to do so due to her busy schedule leading the management of the current COVID-19 outbreak in Sydney. So we're sorry we'll miss Kerry tonight. But thank you to Cathryn, Raina and Ed for joining us this evening. We're looking forward to the discussion. So COVID-19 has had a massive and far-reaching impact on health around the world, but also our healthcare settings and our patients. We've all seen and continue to hear the statistics daily about the number of cases, the number of hospitalisations, the number of deaths, critical bits of information. But we've heard far less about the equally important impact the pandemic has had on other health services. By way of example, here in New South Wales, In 2020, breast screening activity fell by a half. Planned surgical activity in our public hospitals was reduced by a third, and face-to-face consultations in primary care decreased by a quarter. Emergency department visits decreased by 14%, ambulance incidents decreased by 7%, etc. There was a dramatic reduction in the use of our health services. And that's producing a range of impacts that we're starting to hear stories about. One of my colleagues was commenting only a couple of days ago about a patient who had their colonoscopy deferred as a result of the pandemic and has now been diagnosed with widespread colon cancer 12 months later. So the health impacts of this pandemic are really just starting to be felt, and the need for strong and thoughtful leadership is going to be even greater moving forward. But let's start today by looking back at the last 18 months, and I might start by inviting each of our panellists to tell us a little bit about some of their experiences and the things that they've learned. And specifically, perhaps in a couple of minutes, can I ask you to tell us what's perhaps the single most important thing that you've learnt over the last 18 months? And Cathryn, perhaps we'll start with you.
Thanks, Vlado. The lesson really that I've taken out of the last 18 months, and particularly in times of uncertainty, is that you can never communicate enough, and you need to keep that communication flowing. You need to have it evidence-based, but you also need to be honest and admit when there is uncertainty and those shades of grey. And I think that truthfulness is so key when, as I said, you are in this absolute pattern of uncertainty. You don't know what's ahead. We've never dealt with a pandemic like this before. And so you really need to be able to do that and really do that collectively and as a team, so that you can all really work through that uncertainty together and know that you've got processes, protocols, evidence that will help you manage through that time.
Thanks, Cathryn. We're already seeing some questions about communication appear on Slido as well, so why don't we come back to that topic in a moment. But next, let's go to Raina. Raina, what's the most important thing you've learned?
I think I learned about shared air. You know, I always knew about airborne transmission, but there was such a strong ideology that separated airborne transmission from droplet transmission, and much of my research was about masks and respirators, and I showed that respirators protect health workers against respiratory infections, but masks don't work as well. But it was a very unpopular research finding, and there was this very strong ideology about large droplets and contact around influenza, despite there being numerous studies showing influenza as airborne. But the difference last year was that people were dying in much higher numbers from COVID. So it wasn't a myth that could be sustained with such a devastating toll in the pandemic. And, I'll never step into an elevator again without thinking about shared air. I mean, I actually carry a can of Glen 20 in my handbag and I spray it when I get into the elevator, and I wear a mask if I'm in a small closed space.
Yeah, a couple of really interesting concepts there as well, Raina. Thank you, that we'll, I'm sure, come back to over the course of the hour. Ed, let me turn to you now and ask you, what's the most important thing you've learned over the last 18 months?
I think if I go back to my London experience, where I was the Vice-Chancellor of the university with the largest health training role in the UK, but also chaired the coordinating boards for many of the major hospitals in South London, and the boroughs of Southwark and Lambeth, where we had our hospitals, were where the first wave hit the UK. So I remember in a coordinating board meeting, we were talking about how the health system in northern Italy had fallen over with dramatic suddenness. And then within 2 weeks, the wave hit the UK. And we realized that the country was woefully underprepared. The public health capacity had been wound down. There were a ridiculously low number of ventilators in the country and not enough PPE to provide basic protection for staff. So let's not talk about what government got right or wrong. Let's talk about what I learned about our workforce. First of all, almost every final year nursing medical student and clinical academic went onto the clinical front line overnight. Secondly, we turned our two largest hospitals into, in essence, ICU units, with going from about 50 ventilator beds to a total of almost 1,000. These were serviced by orthopedic surgeons, neurosurgeons, everybody rolling their hand up. So the flexibility and willingness of the health workforce to go that extra mile was just absolutely fantastic. And then what I learned as time went by, and this went on and on and on, is that people are just human. Nursing teams that should have 5 people in an ICU only had 3, because that's all we could do. Exhaustion became commoner and commoner. People were off work because they'd been exposed. Huge numbers were off work because they had COVID, and increasing numbers of doctors and nurses were dying in our hospitals. You know, over 1,000 across the NHS, and quite a number in the hospitals that I was involved in. So as this went on, I became increasingly worried about absolute exhaustion in the health workforce, emotional burnout, increasing depression, increasing long COVID. And I realized that this was coming on a situation where the workforce was already stressed. And then an additional factor is that the UK, like Australia, had relied on overseas recruitment of doctors and nurses to make up training shortfalls forever, and that just disappeared overnight. So as I look ahead, I think, and this is I could make many other points about this, but this has just been very much in my mind, that our health workforce is a precious thing. We have to protect it, and we have to make sure it's adequate to the demands that may be put on it by the endemic phase of this pandemic, which is going to go on for a long time, and by any future pandemic events.
Thanks, Ed, and thanks to you all for those important opening comments. There's lots of issues there that we can unpack. And maybe I'll start again by coming back to you, Cathryn, on the topic that Ed just spoke about there, which is the health workforce. We've been very fortunate in this country to be less severely affected, I think, than many other countries around the world in terms of the impact on our community and on our health workforce. But we haven't been unaffected. So, Cathryn, what have you seen, and what impact has that had on the way you think about the way we manage our health services moving forward?
Yeah, Vlado, I would actually say the health workforce has been very impacted, because we went from a period of huge uncertainty. We couldn't get supply of PPE. And I think our workforce has been in a state really of hypervigilance and preparedness actually for 18 months. And, there is a degree, I think, of fatigue. There is a degree of, I don't think anxiety so much, because we know how you can get on top of COVID and manage it. But it's been 18 months. We've got an uptick again. And I think, and we're asking now with vaccination for people to be deployed into unfamiliar areas so that we can make sure we've got fully vaccinated staff in our high risk areas where we might have COVID, in our emergency departments, in our COVID wards and things like that. So taking Ed's point, we're asking our staff just to continually step up. They've got, family that they're worried about. They're trying to homeschool their children. There are so many other things that are happening, and yet we're asking them to maintain that intensity, that effort, because we all know, particularly with Delta, you make a small mistake because you're human, and the consequences are so significant. And so we are certainly supporting staff through a lot of, organisational support, organisational psychologists, making sure we've got counselling available, having flexible work arrangements where we can, but you just have to stay on it every day, because they are absolutely our most valuable asset. And we need to protect them, keep them safe, get them vaccinated, while they're caring for not only COVID patients, but all the other care that we're expecting them to continue to provide.
Thanks, Cathryn. Ed, what advice do you have for us? We're just starting to see the impact of the current wave, I think, on many of our staff and our workforce. What are the things we should learn from the experience?
Well, look, I think that's a really complex question, you know, and the first thing is where is all this leading to? We can see more and more now as we get more and more information from what's going on in other countries. And it's absolutely clear that in countries that have had a heavy COVID load, that is everywhere in Europe, the US, for example, and much of Asia, now Africa, COVID's not going to go away in the foreseeable future. And we're entering an endemic phase where there will be low levels of COVID with spikes, lots of people with with long COVID, long waiting lists, that'll have to be dealt with, and an increasing demand on health systems and a health workforce that's going to go on for a long, long time. People talking about reaching herd immunity, that was difficult even before the Delta variant. We talked about possible herd immunity at 70%. With the Delta variant, it's at least 90% to get herd immunity, and you just can't reach that. It's absolutely impossible. So there's going to be a pool of vulnerable people that will maintain COVID in the background at low levels in most countries, with periodic flare-ups, and probably new strains will emerge. Vaccination is a story in itself. I mean, it's been wonderful that it's reduced deaths and severe illness so much. Of course, the latest evidence from Israel that against Delta, Pfizer gives about 60% infection protection. So that's a significant pool of vulnerability. And there's absolutely no doubt in my mind that we'll need boosters, in every country in due course. So that Israel's decided to do that already. The UK has decided to do it in the autumn. The FDA is vacillating a bit about Pfizer's application in the US, but undoubtedly they will endorse it. The moral issue, of course, is it fair to talk about boosters in countries with advanced health systems when so many people haven't had access to the vaccine at all? And that's and haven't even had their first, including most of Australia. So that's a moral issue. So I think the health system now needs to be absolutely pragmatic about thinking about how we are going to deal with and play our role in a world where COVID is endemic for quite some time to come.
And Raina, Ed touched on the issue of vaccination there. We've heard so much about the challenges in getting population in Australia vaccinated, the issues around communication, the challenges of our scientists and our politicians working together. How do we work together more effectively to counter some of the inappropriate commentary about conspiracy theories and other things with regards to vaccination, to get the right message out? What's your view?
I think, as Cathryn said at the beginning, communication is key, communicating frequently and also acknowledging uncertainty when there is uncertainty. That's like a really important lesson, because people don't think less of you if you say we don't know. They actually prefer to feel like you're being honest and saying we don't actually know about this particular thing. So I think, when people try to communicate uncertainty as certainty, that's when you get into trouble. You say things like, well, I won't make specific quotes, but you can say things that then come back to bite you if you try to be certain when there's a lot of uncertainty. And I think also people appreciate frequent communication, which I think all Australian leaders have done well. We've seen our both our health leaders and our political leaders out there fronting the cameras every day during outbreaks, and that's I think people appreciate that. A lot of people tune in and listen, and but I think also in terms of vaccine hesitancy, we've actually got one of the least hesitant countries in the world. So starting out, we did a study which we published last year that showed that actually most people were willing to take the vaccine, and there were very few, about 2% probably, who are fixed anti-vaxxers, which is consistent with data over the last 20 years in Australia. Anti-vaccination sentiment in Australia is about 2%, but we've got this larger group of people now that are hesitant. It doesn't mean they're anti-vaccination. They just need, health communication, health promotion, and the right messages given to them. But I think in the end, how we work together, you've got to just find the common ground. You know, what's the thing that everyone wants, and put that thing on the table and work towards it. I think we have seen examples of that happening, but in the end, you know, we all want people to be safe in Australia and to be able to resume all the things that we enjoy doing as soon as possible. And that's the common thing that we can all hang on to and try and find that common ground over.
Thanks, Raina. And just a couple of questions on the Slido asking about the role of healthcare leadership in working with government for public health. Do you think healthcare leaders should be more prominent? And do you think we'll see more scientists and healthcare leaders playing more active roles in government decisions in the future?
Was that to me?
Yeah. Raina, if you could say
look, I think we've seen varying levels of that around the world, and some really interesting examples where science has kind of taken a back seat, and there's been quite a strong anti-science agenda in some countries. But in Australia, I think, you know, we've got our expert committees, and we've got a process for formulating advice on different policies, whether it be personal protective equipment or vaccines. So we've had all of that. But I think there's been differences. There's been some hot button issues that have been quite politicized, where perhaps, you know, some experts have taken an evidence-based view, and others have taken more of an ideological view. And there's been quite a lot of really unpleasant you know, interactions between experts, not between government and experts, between experts. And I think, again, we need to just find the common ground and move forward with what we all want in the end, which is, you know, to be safe. Let
me ask Ed, you've been back in Australia now for a few months, Ed, having been in the UK, and so have had first-hand experience of some different models. What's your perspective on this? Healthcare leaders and government working together.
I think in Australia and the UK, the quality of the scientific advice to government has been very high. You know, the modelling advice, the information, and also I might say, as an aside, the intellectual contribution to, you know, finding more about COVID and how to deal with it. Lots come from this country and from the UK. I think in both countries, and indeed in most countries that aren't dictatorships, the political leaders have said that their policy is guided by medical scientific advice. I sometimes think they've said it even a little bit too much, you know, because the medical scientific advice is a crucial background. But a number of these decisions, crucial decisions like when to lockdown, have a political aspect, and in the end they're political decisions, and you can look at the moment about how you know, really major countries are dealing with the current fourth wave. So Boris is letting it rip in the UK. He may back off from that a bit, but that's his current stance. Macron is also you know, opening everything up, but in the context of absolutely draconian vaccination rules and regulations beyond, you know, anything we've seen. So healthcare workers and care workers, even caring in for people in the home, have obligatory vaccination. But basically, if anybody wants to have any contact with anybody else, including going into a coffee shop, you have to be vaccinated. So, you know, so you don't have to be vaccinated in France unless you're a care worker, but you can't actually meet anybody hardly outside the home. So it's just interesting how different countries are starting to adapt to a chronic COVID world, and it's absolutely clear our political leadership has 3 or 4 really major decisions to make here in the next little while, and those decisions require courage. You know, they require real courage.
So let's talk about some of those challenging decisions, Ed. You mentioned the concept of vaccine partnerships, and Emmanuel Macron's been very strong about you know, taking a really firm position on vaccination for travel, for, as you say, coffee shops, but also for people in the health workforce in particular. Where do you think we're going to end up on that concept in Australia? What will be the role of vaccine passports in travel?
I think they're inevitable. Is my view. It's look, I mean, there may be situations where people can't be vaccinated and they have a whole lot of tests and they have a period of significant quarantine to go almost anywhere. But I don't think international travel is going to be possible without a vaccine passport in the future. What Raina thinks, she'll have a view on that. They're the difficult decisions, though. So because as a community, we don't all agree on this. I mean, there's huge disagreement on whether vaccine passports are a good idea, but it's just very difficult to open things up. So the state government in New South Wales is going to have very difficult decisions in the weeks ahead about whether they actually can get down to 0 cases in the community before they open up. Personally, I'm not sure that they'll be able to do that, but we'll see. For Morrison, for the PM, he's going to have to open this country up to a world where there's a lot more COVID floating around than there is in Australia. And how is he going to do that? How is he going to get people in and out of the country again? Because we can't be an isolated lacoon cut off from the wider world for too much longer, or we'll start to our economy will just suffer terribly. It's so he's going to be really tested in the months ahead.
Indeed. Raina, your view on vaccine passports, should we have them in Australia now, or what are they going to look like in the future?
I agree with Ed that they will be inevitable for international travel, and it's not a precedent. We've got yellow fever vaccination requirements for travel to yellow fever endemic areas, so I think we'll see something very similar that'll be kind of worked out internationally. I think in the end, which vaccine you had will matter. It will determine whether you have to go into quarantine at all, what kind of quarantine, whether it's home quarantine or hotel quarantine or some other kind of quarantine. It's kind of controversial to say that now, but that is how it'll pan out, I believe. So that means it's really important. What vaccine decisions we make now have really long-term implications for everybody. In terms of domestically within the country, that's something new, having to show a vaccine passport to go to a restaurant, for example. So I think we'll have some work to do there if that is going to be a system, and also the legal framework for that, whether it's done under public health laws or whether it's done, or whether there are other privacy laws that impinge on that. I think that'll be a more difficult thing to work out, but certainly for international travel, it's going to be required.
Indeed. And some real challenges there for our medical workforce and our health workforce more broadly as well. Cathryn, what's your thoughts about, might we see vaccine passports for people working in healthcare environments? We're told that all aged care staff need to be vaccinated by the end of September, but that hasn't yet been mandated across our broader health workforce. How do we deal with this issue?
Look, we're certainly not in a position yet where we're mandating, vaccination. And I think people to date have shown, I think I'm taking Raina's point there, people have shown great compliance with QR codes. People really have wanted to get vaccinated where vaccines have been available. So we have made sure that we've, communicated the evidence base, the benefits of vaccination, and certainly encouraged our current staff who are in those high-risk areas. So I said our emergency departments, our COVID wards, services where they're certainly providing care to families in the home with COVID. We, of course, have said that those staff, for their safety and their family safety, should be vaccinated. And availability of vaccine really has been, I think, more the issue rather than people's willingness in many respects. But again, it shows that importance of communication and, some of the confusing messaging, that was a very difficult concept about a risk assessment. we were sort of having that conversation almost. And so how was it good one week, but then it wasn't the next week, and the age groups were moving. So I just think, again, that whole aspect about how do you take an evidence-based approach, how do you take all that expert advice and actually turn that into something that is understandable for our staff just as much as the general public. Like it's so important, because once you lose that confidence, it's a very, very hard thing to get back.
And Cathryn, there's a comment on Slido, a question asking about the paediatric workforce and the challenges if there are significant numbers of people perhaps knocked out from work because they're contacts. What preparations have you had to make to address that possible risk in an environment where there's a smaller pool to draw upon, perhaps?
Yeah, look, and it's a very good question, and one that we've thought about a lot. I would say one of the real standouts of the New South Wales response has been the ability to have a centralised point. So, we've had a FEOP, which is a Public Health Emergency Operations Centre, a SHEOP, which is State Health Emergency Operations Centre, but then through a network of our health services. And that ability means that when there have been, surges or upticks in certain geographic areas, we've been able to spread that workload around. We've been able to keep that background of health services going. In the paediatric space, we are very, very conscious that if we took out one of our paediatric intensive care units, very scarce resource, very precious resource. So we've done a lot of planning around that. We're clear about what can we do with swabbing, how can we, we have concierge impacts of anyone who's come into a hospital would have gone through that, answering questions, having temperature checks. Now we've got a lot of that surveillance approach. So I think we've really had a very multi-pronged approach, but we've had lots and lots and lots of planning that sits behind it, so that we've done lots of scenarios about how do we manage that. And sometimes that's not very visible, I think, to all our stakeholders, that we've done that level of work. And we certainly took advice from London. We knew how we could stand up field hospitals, or temporary hospitals as we called them. So, the actual global collaboration was extraordinary as well to do all that planning.
Amazing to hear about all that planning, which is really very much behind the scenes and not out to the public, I guess, unless it becomes necessary. And while we're on the paediatric end of things, Cathryn, children have been a real topic of contention throughout the pandemic, initially with questions about whether schools should be open or closed, challenges around mask wearing, and now debates about the role of vaccination in children and the timing of vaccination. Do you have a view on that?
Look, I think, and Ed again alluded to it, and it's sort of a Slido question that I will respond about, what do health leaders of the future need? And I think it's that ability to understand what a complex environment that we're working in, and the need to be cognizant of economic issues, broader impacts on communities. And so for children, yes, COVID, you will get sick from COVID, but then you realise the impacts on their mental health and wellbeing from being in lockdowns, from not being at school. And like all these things, health leaders are going to have to be very good to juggling ambiguity and making the best informed decisions that they can, but weighing up lots and lots of different issues. So certainly for vaccination, we are looking forward to a vaccination in 2022, and I think again we're seeing that change and those age groups emerge overseas, and we'll take advice. We're very fortunate that we have the National Centre for Immunisation and Research actually in the network. So we'll obviously take that sort of advice to inform the best way forward. But again, it's balancing for children and young people those broader societal and mental health and wellbeing, and quite frankly, some of those impacts over the last 18 months have been very profound and probably more concerning.
Yeah. Raina, do you have a view on this issue, the timing, the optimal timing for consideration of immunisation in children, recognising that some countries are going there now, whereas other countries are saying they're not going to do it at all? Where should we go?
Yeah, I think we should certainly be vaccinating children 12 and up as soon as possible. There's been millions of kids in that age group vaccinated safely. There are some very rare side effects, but you know, kids 12 and up transmit as much as adults do. So in terms of controlling the disease in the population, we can't do it without vaccinating kids. And then I think looking at 6 to 11 years of age, which some countries are doing, there'll be. It's interesting, actually. I think it's because these are brand new vaccines. You know, usually immunisation is a pediatric discipline. The majority of the vaccines on our national immunisation program are for children. But we've seen a sort of flip in the hesitancy, with more concern in some sectors about vaccination of children than vaccination of adults. And it's because these are brand new vaccines. But in the end, children also can get long COVID, including even if they've had very mild infection. We don't fully know the burden of chronic disease that will result from COVID. And, you know, I feel children deserve to be protected from the infection, and that will actually then enable them to go to school safely. It'll keep their teachers safe. And in the end, it'll help us as a society to move forward when everyone is equally protected.
So let's move from the past and the present a little bit and start thinking about the future, perhaps for the next little while. And let me ask you, Cathryn, first of all, how have the changes that we've sort of seen resulting from the COVID pandemic, do you think, changed the hospital of the future and our health service in the future? I know you're planning a new hospital as we speak, so you're the perfect person to answer this question. But how are they going to be different going forward?
The pandemic has shown us I think, acceleration of wearables, digital health, all those sorts of things, remote monitoring, so much more care that we can provide in the home and in community settings. And you know, I think I've read some things about, you know, there will be no hospitals of the future because we'll be able to actually manage everything, not in a hospital. So I don't quite see how we'll be doing some of that advanced surgery, but I think that's really, I think health has been lucky. We haven't had the great disruptors that we've seen in some of the other industries, and the pandemic has certainly meant that whole acceleration to digital health, wearables, remote monitoring, how do we use data, you know, big data quickly and effectively to translate things from the research into clinical practice. And I think vaccination is just an extraordinary example of how quickly you can do that when you need to. So I think we've turned a lot of those things on our heads. So the hospital of the future, I'm thinking, will be probably a lot smaller than it is now, and a lot more care in the community.
Ed, you've got a broad range of responsibility now for hospitals in a range of different countries. What are your thoughts on hospitals?
I think Cathryn's touched on some of the key points. A whole lot of change that was happening in any case has been greatly accelerated by the rapid adaptations that have occurred in the COVID pandemic, and we won't be going back. So the integration of information in the health system from the patient perspective, much better longitudinal integration across the patient journey, as Cathryn implied, acceleration of the move from a hospital centre to a community-centred model for chronic illness, taking advantage of all of the technologies. And then just a couple of, I suppose, less exciting things in a way, but the the brutal exposure of our workforce problems that alluded to earlier, that will need absolutely urgent attention, or we won't have people to run health in the way we need. And then the other thing not to forget about is the brutal exposure of the inadequacy of global supply chains when everything is just in time. And we're going to have to think very differently about what is made in this country, what is stored in this country, how we sort of have a much better buffer. So disastrous situations like the UK not having enough PPE to protect doctors and nurses for the first 6 months of this pandemic don't occur again.
What does that mean in terms of training, Ed, from your perspective? What do we need to be doing differently in terms of training?
Well, I think it would be trite to say we need more, because that's true. We need greater capacity. So we need to make health career. First of all, we need to take responsibility as Western countries for training our own workforce rather than relying on imported professionals in large numbers. I mean, that's both immoral and now ineffective. So we've got to make some health careers much more attractive than they are at the moment. And secondly, and I think more importantly, much of the health workforce needs to be restructured. We need to see new types of professional skill sets emerging for the health workforce of the future. I mean, I know you and I have discussed this quite a lot. I think it's a really exciting opportunity.
Yeah. Raina, what are your thoughts? You've led a school of public health. It's the topic of the hour. Where are the skill gaps that we need moving forward? What are the areas that you think we need to focus on?
I think field epidemiology and outbreak response was clearly a skill gap we saw all over the world. People who had different kinds of backgrounds, but not that kind of training, not even public health training in some instances, kind of leading the responses in various countries, who had to learn as they went. They had to learn about contact tracing and what it was and why it's done. I think there's not much awareness that there is a specific science called field epidemiology where people are actually trained in the science of outbreak response and control. And it's not very, it's extremely costly to have your experts learning on the job in the middle of a pandemic, which is essentially what we saw everywhere. And including in the US, largely because the CDC, although they've got all the skills, were kind of gagged and bound and not allowed to do their job. So yeah, I think that's a major skills gap.
And we saw early on lots of discussion about the differences between the way the Victorian and New South Wales public health units were structured. How important do you think that's been in terms of those, at least the early responses to the pandemic?
It was critical. So in February, March, we saw really commendable effort in Australia to expand ICU bed capacity and ventilation capacity. It was expanded more than 125%. So there was certainly an awareness that you needed to expand acute hospital care, but zero awareness that you also needed to expand public health response capability. And fortunately for New South Wales, there has been much greater investment in the public health outbreak response, public health units. When I say public health, I don't mean public hospitals. I mean, the public health response capability. So New South Wales Health was in a much better position, whereas in Victoria, and this, I worked at the Royal Melbourne and in Melbourne for more than 20 years ago now. And it was about the time I was there in the 1990s when the health system in Victoria started to be stripped away. And by the time, which is, you can get by in the good times with a bare bones system, but when you have a pandemic and you need massive surge capacity, that's when everything falls apart. And that's what we saw in Victoria. They just did not have the resources to deal with what they needed to deal with. They couldn't keep up with the contact tracing. They couldn't manage all the outbreak response, and it just got totally out of control.
Are there gaps now, still today, that we need to fill moving forward if we're going to help make our health system more resilient in the public health area specifically?
Yeah, I think we need more training in outbreak response. We need it formally recognised as a science, that you actually need people who understand what they're doing. And still in Australia, there's not that many people who understand all the nuances of epidemic control. And I think it's a global issue. There is a shortage globally in field epidemiology.
Sounds like a job for us to take on at the university. Cathryn, maybe a similar question to you about our hospital system and our broader health system. Do we have the skills that we need? And what do we learn from the pandemic in terms of the sort of people that we need, that maybe we don't have enough of or don't have any of at the moment? What are your thoughts?
Yeah, look, certainly the approach has been, I mean, we were moving to that anyway. We've always had multidisciplinary care. I think what became very evident to me, which we stood up quite early on, was a clinical council. And that provided that great interdisciplinary interaction and conversation, and much more patient-centred care, again as Ed has alluded to, which is really where we need to go. I think that means that we need to think really hard about our workforce of the future, and more around skills and capabilities, so that we don't get too stuck in a label, and how you have an approach, as said, which is around skills and capabilities and expertise, because we've shown that to respond in these sorts of situations, you actually need to have that ability to be really flexible, to be able to work in different environments. And I'm not sure that we're supporting our staff to be able to do that comfortably, and to make sure that when we're asking them to work in unfamiliar environments, that we've got the right mechanisms in place to do that. I think what we need to absolutely also have is people working at the top of their practice. So, you must have people who have spent a long time getting trained, they're unbelievably skilled and very experienced. We need them. So we need, nurse practitioners, we need allied health, we need those people to be absolutely top of scope of practice. Yeah. Because, we're not going to have the luxury of the numbers that we need into the future. We're going to have an enormous loss, because you look at the nature of our workforce, we've lost a lot of people. People have made different decisions through this last 18 months, have contemplated life and what's important. So I'm not sure that we've got the numbers, and we need to confront that and deal with it.
Thanks, Cathryn. Raina, did you want to comment on that?
Yeah, just on that point of the loss of health workers, we've heard that around the world, of people leaving nursing or medicine and other allied health professions after their experience in the pandemic. And some Australian researchers published a paper last year on moral injury among healthcare workers. We had 4,000 health workers infected in the Victorian second wave alone, because the guidelines said, treat COVID patients wearing a surgical mask. And there was a lot of reluctance to change those guidelines, and eventually in Victoria they changed them at the time. But I think the kind of, because I've done research in PPE, I've had health workers all over the world contacting me about this issue, and it's just unbelievable stories of being, I mean, I know people who lost their jobs because who were told not to come to work, to take leave because they dared to bring an N95 respirator to work to protect themselves because the hospital wasn't giving them one. So, I think the work health and safety side of it just failed everywhere. You see images of the cleaners going in to clean the TAB after one patient has been in there. They're wearing the full Tyvek suit and the hazmat gear and a respirator and boots, and they're going in there like little spacemen. And we're telling our health workers to go in with a surgical mask and a flimsy little gown. and they're exposed to it constantly, over and over and over again. It's an airborne virus. So I think health workers have really suffered, and we need to change the way we approach work health and safety for healthcare workers.
Yeah, important comments, and they're our most precious resource in fighting disease amongst our sickest patients. Cathryn, just to come back to you, you talked about the skills people needed perhaps as a focus rather than the roles. And one of those really important skills which has become so critical over the last 18 months has been leadership. What are the specific skills you think we can help our people in health develop to make them better leaders, to really grow the quantum and the quality of the leaders that we have in the health system?
Yeah, look, you could have days of debate around leadership. I think that's the thing. There's so much literature. There's so much evidence. I would say the ability to lead in times of ambiguity and uncertainty. You know, we've all talked about that many times, I'm sure, is really such an important skill to have. So you've got to be able to manage yourself, and by managing yourself, then you can assist and lead others. But unless you can get to your point of calm, understand your limitations and maybe your anxieties, so you've got to be able to be that ability to have a good hard long look at yourself just as much. And then have all those sorts of capabilities that we know great leaders have, the ability to communicate, the ability to certainly take complex issues and communicate those, again, very simply, be open-minded and be able to influence and listen and collaborate and work with others, because that's the only way that you can do and get through things that we've certainly been facing in this pandemic.
Ed, you've been in various leadership roles at very senior levels. What do you think?
Look, I think at coal face level, the leadership of the health workforce in Australia and the UK has been phenomenal. I mean, people have just stepped up and done what has to be done under huge pressure. I think also, and I think this applies to the UK and Australia, the high-level scientific and medical advice given by leadership to government on the whole has been pretty good. When I see Kerry Chan speak, she seems clear, forthright, and very firm and correct in her views. I think probably where there have been significant failures of leadership in the pandemic, and perhaps I'm referring more to the UK here than Australia, it's been more at political level, where the really difficult things, people have been a little afraid to be seen to do too quickly. So there's no doubt that the UK for the first half of this pandemic was slow on everything. I mean, it was why for a very advanced country with a good health system, it had the highest per capita death rate in the world for a long time. It's sort of been saved, thank goodness, by the good vaccination policy. It's really hard for political leaders to make decisions that impair the economy on the one side and trade people's health off on the other. It gets to the stage eventually where it's a very difficult decision. I mean, there's a level of COVID where it's much more damaging probably to keep society closed down than to open it up for the mental health problems alone. But these are really difficult political decisions, and they're not solely health decisions, these things. So I sympathise though with people who've had political leadership positions in recent times, because I ask myself, when Boris seemed to make a bit of a mess of it on so many occasions, and he was badly affected by COVID himself, would I have done any better? It's just been really tough, and will be for a while.
So we're almost at the end. We've covered a lot of the Slido questions. I apologise we haven't been able to get to all of them, but we've tried to get through as many as we can. There's one question there I might get you to comment on, Raina. Got the opportunity of having you here. So can I get you to speculate on the prognosis for the pandemic, perhaps focused here in Australia? Someone's asked how long before we get on top of it and what will that look like? What are your thoughts?
Well, getting on top of it means high levels of vaccination. That's the bottom line. We're in a very vulnerable position right now because we've got outbreaks of Delta and we've got a substantially under-vaccinated population. Only about 11% fully vaccinated and about 35%, I think, partially vaccinated, which makes us sitting ducks, right? This is a more dangerous virus. It's got a higher chance of putting you in hospital, ICU, or killing you, and it's much more contagious. So we're dealing with, the worst variant of concern we've seen to date in an under-vaccinated population. But we've got a small time period on which we've just got to hold the line until we can get those supplies coming in and get everyone vaccinated. I think we should be able to manage that pretty efficiently. Most of the states have really ramped up their capacity to vaccinate. They're just waiting on the supplies. And then, of course, but we need to be thinking ahead and planning for the boosters. We don't want to be in this position all over again next year when we've got a brand new variant and we haven't got the booster for it because we didn't organise it. So we want to be proactive and make sure we're not in this situation again, because I think we will need boosters. It will be a moving feast. We'll just have to keep up with it. And as long as we have vaccines that can give reasonable protection against hospitalisation and death, we should be in a reasonable position.
Thanks, Raina. So we're almost out of time. To finish up, perhaps I can ask each of you in just 30 seconds or so to tell us what you think the biggest change we'll see in healthcare will be in the next 5 years. And Ed, I might start with you.
I think, well, I hope it's within 5 years. I think much greater integration of modern informatics systems, linking community to hospital, to post-hospital healthcare, and much greater empowerment of patients as a result.
Thanks, Ed. Cathryn?
Those things as well, but I think we're finally going to see the precision medicine and the advanced therapeutics just really take hold and accelerate. I think the opportunities are just phenomenal, and in the next 5 years, given what's just even happened in the last 12 months, will be really exciting.
Thanks, Cathryn. And Raina, last word to you.
I'm going to finish on something controversial and say that I think we haven't heard the end of gain-of-function research. It's an issue that was stomped on very violently at the beginning of the pandemic, but it's resurfaced, and I think we will see changes to the regulation and oversight of gain-of-function research in the years to come, and that is an important change that will potentially reduce our risk of facing a pandemic like this again.
Thanks, Raina, and thanks on behalf of UNSW Medicine and Health and all of our people who've joined us today. We'd like to thank all of you for the conversation today. It's been fascinating. It's been fantastic to look back at how far we've come from the challenges we faced at the start of the pandemic, the important role that leadership, particularly health leadership, has had in managing not just the health aspects, but the broader community response to COVID, and what we've all learnt as a result, the important and broadened role for our health workforce and our health system, I think, in the community moving forward, and the ongoing need for us to continue to develop and learn some of the lessons from the changes we've experienced over the last 18 months to redefine how our health workforce looks moving forward. I think, Cathryn, you described at the beginning the fact that health had been lucky not to have been hit by a disruptive event previously. Perhaps we've been unlucky previously, actually, to have been hit by not to have avoided disruptive events, and this is what we needed really to push health forward. So maybe that's a little bit of a silver lining to the COVID cloud. I hope you've all enjoyed this session tonight. Clearly, there's never been a more important need for leaders in healthcare settings to drive change and implement activities across the sector. Here at UNSW Medicine and Health, we're proud to have many stellar researchers working on COVID, on the healthcare system, and to be supporting New South Wales Health in its efforts to control COVID, including with many of our staff being seconded to the department. We have the oldest health management program in Australia, training thousands of students over 64 years now, and we're doubling down in this area by launching a new health systems theme across the faculty to help address some of the sorts of challenges that we've discussed tonight. So watch this space. Thank you to all of you for dialing in to this discussion. We hope it's been interesting and entertaining and you've learned something. This webinar has been recorded and will be emailed to everyone who pre-registered, so feel free to go back and look over some of the highlights if you like. And please also look out for information on our next MedConnect event in October by following us on social media with the handle @UNSW Medicine. Thank you very much and good night.